My name is Dr. Aditya. I work as a consultant in critical care medicine department at Apollo Jubilee Hills. My area of expertise is surgical intensive care unit. I'm affiliated to as life member to Indian Society of Critical Care Medicine, the Intensive Care Society, and European Society of Critical Care. I did my fellowship in infectious diseases. I hereby welcome every one of you to the Neurocritical Care Update 2022. I thank my Hyderabad ISCCM chapter and our Apollo Critical Care Unit for giving me this opportunity. Let us talk about neuromuscular diseases in ICU, a case-based approach and evidence-based management. Coming to the neuromuscular diseases, they could be of three types. That is pre-existing neuromuscular diseases, a new onset or undiagnosed one, and ICU-acquired critical care illnesses. This is a broad classification showing various neuromuscular diseases we could encounter, but most commonly we encounter this Guillain-Barre syndrome, Myasthenia gravis, and critical illness, polyneuropathy and myopathy. Let's start with a case scenario. A 56-year-old female was brought to ICU with a complaint of acute onset weakness of both her limbs. For 4 hours, there was history of diarrhea 1 week prior, and ICU examination revealed more weakness in the lower limbs of 2/5 with relatively sparing of upper limbs by 3/5 weakness, and there was noticeable loss of muscle tone and deep tendon reflexes were absent. All the higher mental functions, the speech, the memory, and cranial nerve examination was normal. So what do you think of this? So as the deep tendon reflexes were absent and typically the paralysis was kind of ascending paralysis and loss of muscle tone is present, I would think of as a variant, one of the variants of Guillain-Barre syndrome. And most common one is acute inflammatory demyelinating polyneuropathy, which accounts to 90% of the cases of AIDP. This is quite rapidly recovering one along with Aman variant. And typical of this is anti-GM1 antibodies are detected in AIDP, and in Aman variant, anti-GD1A antibodies are more common. And coming to the other two variants, is AMSAR and Miller-Fisher variant. This is combined sensory and motor axonal neuropathy is seen. And Miller-Fisher variant, there is ocular involvement, that is ophthalmoplegia, ataxia, and areflexia is more common. And diagnostic test of choice is anti-GQ1 antibodies, which is present up to 90% of the patients in the Miller-Fisher syndrome. And these are the GBS mimics. These are the various differential diagnoses we should think of. How do we exclude? These are myasthenia has sparing of the reflexes and more ocular involvement. Botulinum has descending kind of paralysis contrary to what we see in Guillain-Barre syndrome. Tick paralysis, shellfish poisoning, toxic neuropathies, organophosphorus poisonings, all these have exposure histories. And in patients with porphyria, there is abdominal pain and mental disturbances. And in poliomyelitis, there is preservation of the sensation, which is typical. And in periodic paralysis, there is clearly evident electrolyte abnormality, which after correction, the paralysis typically improves rapidly over the next 1 to 2 days. And in critical illnesses, there is history of prolonged sepsis and multi-organ failure and chronic diseases which confine the patient for multiple days of stay in ICU. Coming to the diagnosis, the CSF will show albuminocytological differentiation. The CSF glucose is normal, and nerve conduction velocities decrease up to 80% of the normal in the proximal nerve segments. And history of exposure to the infections prior, like HIV, Epstein-Barr virus, cytomegalovirus, and in our patient, Campylobacter jejuni and mycoplasmal infections are common. Management, airway, breathing, circulation comes first, and in these patients of neuromuscular disorders, it is very important and paramount to secure the airway at the earliest, because these patients tend to have rapidly progressing ascending paralysis. There could be shallow breathing, the voice phonation may be low, the progressively getting low, and there could be pooling of oral secretions. So Roper and Keene criteria, intubation criteria is used. That is reduced tidal expiration. We always look for reduced tidal expiration, oropharyngeal paresis, falling in vital capacity over 4 to 6 hours, and any clinical signs of respiratory fatigue. The treatment of choice is plasmapheresis and intravenous immunoglobulins. Intravenous immunoglobulins are given over 5 days with each day dose of 0.4 gram per kg body weight per day. And coming to plasmapheresis, albumin is used as exchange fluid of choice with a total of 200 milliliters per kg body weight exchange on alternate days, preferably for the next 7 to 14 days. And this IVIG plasmapheresis, the patient with mild Guillain-Barre syndrome, which mild means the patient who is still little ambulatory with the help of support, it typically improves after 2 sessions approximately, and the patient in moderate to mildly severe people improve with 4 sessions. And in severe Guillain-Barre syndrome, people will not usually respond to 2 more additional sessions also. Multiple studies have been done comparing intravenous immunoglobulins and plasmapheresis, which is more effective. And all the studies in the past have revealed that both are equally effective and anything can be used in our patients. And coming to the contraindications, because the intravenous immunoglobulins contain 95% of IgG, trace amounts of IgA, and rest is IgM. So the patient with absolute IgA deficiency should not be exposed to trace amounts of IgA, which is present in intravenous immunoglobulins. And in patients with renal insufficiency, since sucrose is present in the intravenous immunoglobulins, these patients with renal insufficiency have accumulation of sucrose in the proximal convoluted tubule, which will lead to the osmotic nephrosis, leading to acute tubulointerstitial nephritis. So the treatment is beneficial if given within first 4 weeks for plasmapheresis and within the first 2 weeks for the intravenous immunoglobulin starting from the symptom onset. Corticosteroids are not recommended in acute inflammatory demyelinating polyneuritis. Yes, they have role in chronic inflammatory demyelinating polyneuritis whose symptoms persist beyond 6 months. And treatment of plasmapheresis should not be followed by again 5 sessions of intravenous immunoglobulins. Coming to the next case scenario, a 66-year-old female was brought to our emergency by her daughter with progressive neuromuscular weakness. There is drooping of eyelids, difficulty in talking, difficulty in swallowing, pooling of oral secretions. So clearly she has bulbar weakness. She was unable to walk more than a step or two. She has a history of similar complaints in the past, which used to subside immediately after medication. This is your clue. So what are your thoughts? So probably the patient has myasthenia gravis. And this patient, I have not put in the case scenario, but she is a known case of myasthenia also. So these patients tend to have on and off symptoms. So let's come to the brief pathophysiology. This is our typical neuromuscular junction. These are seminal vesicles with acetylcholine being released into the neuromuscular junction, which act upon the acetylcholine receptors, leading to the strong electrical nerve response. In myasthenia gravis, since the acetylcholine receptor antibodies are joining on the acetylcholine receptors and making them inactive, all the acetylcholine which is present is getting wasted, and there is very small to negligible electrical response being generated. And these people have typical cardinal sign of fatigability and weakness. That is, if they keep on doing the same activity again and again, the muscles will fatigue easily. And early cranial nerve involvement is seen, including ptosis and diplopia. When the patient attempts to smile, there could be snarling of expression, and the speech could have mushy quality with a brief nasal timbre. Bulbar weakness is more prominent in MuSK antibody, that is muscle specific kinase antibody positive myasthenia gravis. This is another variant, another antibody variant. Coming to the cardinal features, the weakness typically generalized and is confined to proximal muscles in 85% people, and some people may have asymmetric kind of weakness also. When the weakness is persistent only for the ocular area for more than 3 years, we can consider it as ocular myasthenia gravis. And when would you call a patient is in myasthenia crisis is that a known myasthenia patient with respiratory failure or respiratory collapse secondary to exposure to infection or a stressful condition like a surgery or presence of any hyper or hypothyroidism and electrolyte abnormalities may precipitate myasthenia crisis. Coming to the diagnosis, edrophonium hydrochloride of 10 milligrams is given IV, which transiently improves the muscle weakness, is called positive edrophonium test, which concludes the diagnosis of myasthenia gravis. And if you have any doubt regarding the positivity of the test, it should be considered negative. Coming to the serological testing, anti-acetylcholine receptor antibodies are detected in almost 85% people, and those who don't have these antibodies are termed seronegative. And in this seronegative group, 50 to 70% will have anti-MuSK antibodies who tend to have more severe kind of disease. This is your typical neuromuscular myasthenia gravis worksheet. Degree of disability is graded in the various aspects like generalized weakness, diplopia, ptosis, arms, legs, speech, voice, chew, how strong is the chew, swallowing, and any respiratory discomfort. And And coming to the approach, if there is only ocular involvement is there, we give pyridostigmine and it is unsatisfactory, go for direct immunosuppression rather than evaluating for surgery, thymectomy or IVIG and plasmapheresis, because in ocular myasthenia gravis, oral prednisone is found to be most effective. And coming to the if the patient has generalized weakness, then we should evaluate for thymoma. And if thymoma is present, the definitive surgery should be executed. Before definitive surgery, we do a plasmapheresis session or we do transfuse intravenous immunoglobulins to prime the patient and optimize him to relieve him from the weakness before the patient is posted for the thymectomy. And in crisis, the treatment of choice is plasmapheresis or intravenous immunoglobulins. If not responding, we go for immunosuppression. The treatment options are pyridostigmine is the drug of choice, 15 to 30 milligram every 4 to 6 hours with incremental dosing depending upon the patient response. Short-term immunomodulating therapies are IVIG and plasmapheresis. And coming to corticosteroids, like we spoke in ocular myasthenia gravis, oral prednisone is the drug of choice, which is proven to be more effective than intravenous immunoglobulins and plasmapheresis. Coming to non-steroidal alternatives, azathioprine, cyclosporin, tacrolimus, and cyclophosphamide plus rituximab in the resistant models. Patients who are allergic to azathioprine can be given cyclosporin, and those who have renal failure, tacrolimus is the preferred drug because it causes less nephrotoxicity. Thymectomy is a definitive therapy in generalized people, and in rehabilitation, especially the people who are undergoing rehab, these people should not be advised incentive spirometry because this will cause respiratory fatigue again, these people, and they end up in the respiratory compromise. Occupational therapy is very important because these people are taught how to conserve the energy with the compensatory techniques so that they could perform the daily living tasks with ease. Coming to the third case scenario, a 34-year-old gentleman with fat embolism syndrome following road traffic accident is being ventilated for type 1 respiratory failure for the past 7 days. He was not on any antibiotics now and seemed to be improving with improving gaseous exchange over the past 48 hours. So on day 7, the sedation was stopped. He was calm and comfortable on pressure support ventilation, generating decent tidal volumes. So a plan to liberate him from ventilator was being made and spontaneous breathing trial was given with T-bar. After 20 minutes into the spontaneous breathing trial, he was having tachypnea, tachycardia, and he was clearly in distress and put back on the pressure support ventilation. So after 1 week stay in the ICU and prolonged sedation, the patient probably has ICU-acquired weakness. What are the different types? Critical illness neuropathy, critical illness myopathy, and neuromyopathy. The major cause of morbidity in survivors of critical illness. ICU-acquired weakness is paralysis is mostly due to abnormal inactivation of the sodium channels. So the residual blockade of neuromuscular junction after discontinuation of the neuromuscular blocking agents is responsible for persistent weakness. And once these agents are withdrawn, the recovery occurs after some time. ICU-acquired weaknesses nearly always cause sensory motor neuropathy or by acute myopathy. Critical illness myopathy is a major contributor to severe ICU-acquired weakness. And as we spoke, it is due to increased sodium channel inactivation without the actual nerve damage. Actual nerve damage can also happen, like you can see in this picture, because of microcirculatory changes. There is impaired perfusion and oxygen delivery, causing neuronal damage. Alteration of the muscle structure happens. At the same time, the nerve membrane inexcitability or hypoexcitability occurs, and muscle function decreases. And at the same time, muscle atrophy increases in the way because the patient is an immobilization with disuse atrophy, unloading, mechanical ventilation, and functional denervation with the background of increased catabolism compared to the anabolism because of the neuroendocrine alterations will lead to increased muscle atrophy and decreased muscle function, both contributing to weaning failure from the ventilator and ICU-acquired weakness. This slide is beautifully showing modifiable and non-modifiable risk factors. These upper half shows the non-modifiable risk factors, which are female sex, premorbid obesity, and highly severe infection, which contributes to the ICU-acquired weakness. And the modifiable ones, which we have to attend, are hyperglycemia, parenteral nutrition, drugs, and immobility. Immobility will be taken. How we counter these modifiable risk factors is early rehabilitation techniques. And drugs is we withdraw the corticosteroids, vasoactive medications, sedation, and neuromuscular blocking agents as early as possible. Parenteral nutrition early in the course of ICU-acquired weakness is not at all recommended. I'll show you the evidence in the future slides. And hyperglycemia has to be countered because this in the previous slide is clearly triggering the mitochondria, causing more reactive oxygen species, decrease in the ATP production, and causing insufficient autophagy and decreasing the muscle function. These are the diagnosis tests of the to diagnose ICU-acquired weaknesses. Each have their own merits. Nerve conduction studies and electromyography are the diagnostic tests of choice. Muscle biopsy is invasive test is usually reserved for the inconclusive tests. Coming to the creatine kinase, critical illness myopathy, there is abnormally high elevation of up to 10,000 international units titer of creatine kinase in critical illness myopathy, which will differentiate it from neuropathy and neuromyopathy. Coming to the diagnosis of ICU-acquired weakness in ICU, point of care ultrasound can be used to look for the bulk of the muscle, the fat deposition in the muscle, that is adiposity, the fibrous nature of fibrous deposition within the muscles to quantify the amount of atrophy in the muscles. Coming to the treatment, there is no proven treatment, only supportive therapy can be provided. What we can do is provide intensive insulin therapy, which is found to be effective in at least in the early stages to prevent the patient from developing ICU-acquired weakness. As we spoke, no early TPN because ketone bodies either through stimulation of endogenous ketogenesis or through infusion of exogenous ketones is shown to protect against sepsis-induced muscle weakness. And we should always minimize sedation and early rehab. Neuromuscular stimulation was tried early, but it is still being tried, but it did not reveal any significant improvement in this particular study. And drugs like anabolic steroids, growth hormone, glutamine, immunoglobulins are not recommended because they are not shown to be of any use. What we can do as intensivists is that we should advise for rehab in and beyond ICU. That is, because of the prolonged immobilization, there are skin ulcers, compression neuropathies, joint ossifications, low mood, and deconditioning. So these people require physical activity, mobilization, and exercises, which will, and along with cycle ergometry, like you can see in this particular patient, these have been found to be safe and useful if done in a proper manner. So the patient has to be restrained properly, the lines have to be secured, the drains have to be secured, and the patient on endotracheal tube has to be secured. Multiple people may be required. There could be some logistical issues, but these have to be addressed in order to prevent the patient from developing ICU-acquired weakness. Like we spoke, this ICU-acquired weakness could be circuitous, that is the endpoint. We may not know when the endpoint is. Some people may take longer than usual duration to recover. It could be weeks to months, and some people, even after recovering from the primary illness, will require long-term ventilatory support. Thank you.